Good afternoon, ladies and gentlemen. For the next 20 minutes or so, we will talk about the presentation of Parkinson's disease. I'll be touching on the typical features of how a Parkinson's disease patient would present to you when they come to your clinic, the common misconceptions about how the features should present, and the atypical features, that means signs that we should look out for that would tell us that this patient may not have Parkinson's disease but may have an alternative diagnosis. So we'll be covering a little bit of epidemiology and some basic pathophysiology, which I think would be useful in the understanding of what happens in the patient with Parkinson's disease and why are dopaminergic agents useful in these patients. So just to put everything in a nutshell first, as the first slide, Parkinson's disease is a progressive neurodegenerative disease, and basically the presentation is divided into the motor symptoms and the non-motor symptoms. Motor symptoms, everybody knows what they are, the three cardinal signs: the tremors, the rigidity, and the bradykinesia. And these come about because there is degeneration of neurons which use dopamine as the neurotransmitter. And this happen in the extrapyramidal region of the brain. That means in the substantia nigra and the projections going into the basal ganglia. Therefore, if there's deficiency here, you would present as the motor symptoms. Now, the non-motor symptoms are very often neglected, forgotten, and sometimes we don't really realize that the patient really suffers from the non-motor problems. And these usually come a little bit later in the progress of the disease, usually not so prominent in the early years. But the patients suffer because, firstly, these symptoms do not benefit when you give the patients dopamine agonists. In fact, some of them are dopaminergic agents. In fact, some of them may even worsen treatment. And these are the problems that they have, like dementia, hallucination, postural hypotension. Just a bit about epidemiology. Parkinson's occurs in throughout worldwide in all ethnic groups. Predominantly in the elderly. Usually the onset is in the 60s, but not to forget that even the young can have Parkinson's disease. So in Singapore, the prevalence is about 0.3% for the population who are aged 50 years and above, and it occurs in all races. And the prevalence of 0.3 is about the same worldwide. In papers which were written in the Western countries, this is about the same prevalence. And if we have hit the age of 60, then about 1% of this population would have had Parkinson's disease. Not to forget, if the patient presents with Parkinson's disease before the age of 40, then these are called the young onset Parkinson's disease. And they can even occur in patients as young as even less than 20, and this would be the juvenile onset. Younger patients generally have a higher risk of having a genetic cause as the underlying reason for having Parkinson's disease. So just some basic pathophysiology to understand what goes wrong in the patient with Parkinson's. When you say a patient has idiopathic Parkinson's disease, it doesn't really mean that the patient has a single condition, because different patients have different mechanisms behind Parkinson's. It may be in the sporadic form. It may be in familial forms. Familial may be autosomal recessive and also autosomal dominant. But all of them share a common problem. And the common end problem is that you cannot get rid of the garbage in the brain. And the garbage here is actually the proteins which have misfolded, proteins which are damaged in the neurons. Normally, in a normal person, we should be able to clear this using what is called a ubiquitin proteasomal system. So we get rid of the proteins and it is sort of broken down and recycled and used again. But for patients with Parkinson's disease, for some reason, they are unable to clear this, and this protein is then tucked away in the corner in the cell in the form of a Lewy body. So this is the one which appears to be pink on staining. And the cells that contain Lewy body also degenerate. They undergo apoptosis and they die. And the regions which undergo apoptosis would generally be the substantia nigra, and other areas associated with it. But do remember that the non-extrapyramidal regions also are involved, and this accounts for the non-motor symptoms in Parkinson's disease. So this is where the substantia nigra is, and if you cut through axially, this is what it looks like. This is atrophied in the patient with Parkinson's disease. The substantia nigra has projections going into the basal ganglia. And in a normal person, what it does is it facilitates our motor movements. So if the substantia nigra is knocked out, as in Parkinson's disease, you lose this facilitation, and this is how it manifests itself as slowness in movements and as rigidity. Way back in 1817, when Dr. James Parkinson noted some, they were not his patients actually, he noted some people who were staying around his area that he met every day on the street having these features, and he described them as having involuntary tremulous motion in the parts not in action. So he noted that they were rest tremors. He noted that they had a propensity to bend the trunk forwards with a shuffling gait. And he also noted that in the early stages, the patients had uninjured intellect. So these patients were not demented in the early stages. And we can see that his description remains true up to today. So if a patient walks to your clinic with features of Parkinsonism, how do we come about to diagnose these patients? Is there a special MRI sequence that would diagnose this, or can you send some blood tests to diagnose Parkinson's? Actually, no, because there is no single reliable marker that is more sensitive than the clinical assessment of a patient. And the clinical assessment basically is to look for the presence of Parkinsonism. You need to exclude whether the patient has atypical features which tell you this is not Parkinson's disease, and to see how well they fit into the diagnostic criteria of Parkinson's disease. So chances are, if a patient comes to your clinic with Parkinsonism, 75% of them perhaps would have Parkinson's disease, but we should not neglect and forget the 25% who have other conditions which may mimic Parkinson's disease, because many of these conditions are actually curable, unlike Parkinson's. Yeah? They can be reversed, can be treated, or they can be cured. For instance, Wilson's disease, if the patient has hydrocephalus, you can just put a shunt in. Even if the patient has Parkinsonism due to strokes, you can halt the progression of strokes by managing the risk factors. There is also another group of neurodegenerative diseases, the atypical Parkinsonian disorders, and this would be the multiple system atrophy, progressive supranuclear palsy. These conditions do not have a cure. We don't have a cure for them. They normally have quite a bad prognosis, and they are quite difficult to differentiate from Parkinson's disease in the early stages. So later on, I will discuss the features that you would want to watch out for to tell you that this may be one of the atypical Parkinsonian disorders. So this is how I feel we should approach a patient who has Parkinsonism. Yeah, he walks into the clinic. Does he have Parkinsonism? That's the first question. If he does, look for the atypical features to suggest that this is something else and not Parkinson's disease. If there are no atypical features, then you move on to see how well he fulfills the diagnostic criteria, because this will tell you how accurate your clinical diagnosis is. So firstly, to confirm the presence of Parkinsonism. Parkinsonism refers to these three cardinal features of Parkinson's disease, which is the rest tremors, the rigidity, and the bradykinesia. So you want to watch out and see whether the patient has these three conditions.